Great, thanks. Paul, you're on.
Yeah, okay. Sorry, Jill, can I get a comment on the fact that this patient now has had UC for 10 years and she's 25 years of age now? Can you give us a...
Well, so, I mean, the obvious thing is she needs to start having surveillance colonoscopies. And depending on the severity, that would depend on the interval that would be required.
May I ask,
I don't know if there's, yeah.
Is the patient Caucasian?
Yes, she's white patient.
The reason I'm asking is that I wonder if Jill, in an ideal world where you had all the resources possible, despite the fact that she doesn't have a family history, given the severity of a phenotypic presentation, if you were in a research center, is this somebody you might consider to test for monogenic type IBD or not quite? Because she started 10 years.
She's too old.
In her teens. She's too old.
No, she's too old. Yeah.
Okay. All right. None, I saw you on. Do you have any comments or questions?
Oh, hi. Good afternoon, everyone. Hi, Mesh. Sham, I'm just listening. I have no question, no comment tonight, this evening. Thank you.
Okay, None.
That's just one other point about tofacitinib that I didn't make, and I think Impa was trying to make that point, is it is contraindicated in pregnancy.
Yeah, fair enough. Fair enough. Professor Cassinides, any questions? Any comments?
Oh no, sorry, I'm a purveyor today. Sorry, I missed half of it, and I'm just clocking in now. We have more pressing issues on our brain with this viral hepatitis convention next week. Apologies, I'm here but not here. Very nice, thank you.
I can imagine that. I can imagine that.
Sorry, Joe. Sorry, quickly. If TOFA, she develops resistance, I don't know about that. I haven't heard about it. I believe that the new JAK inhibitors might work because they're different pathways, isn't it? The JAK1, TYK2 combination. So UPA or something like that.
Yeah, so TOFA is a pretty durable drug.
Yeah.
There is, I suppose, no reason you could try one of the other JAKs, and I certainly would be. So upadacitinib is emerging. Obviously, there are no head-to-head studies, but if you look at network meta-analyses, which are in direct comparisons of different agents, and there have been a number that have been published in the last 18 months, upadacitinib is coming up way, way, way superior to the other JAKs in terms of ulcerative colitis. So, yes, most definitely an option.
Correct, yeah.
Filgotinib doesn't appear to be quite as effective, and it failed, as with tofacitinib, it also failed its phase 2 Crohn's studies, phase 3 Crohn's studies, and tofacitinib obviously failed its phase 2 Crohn's study. So it's not quite clear why JAK inhibitors don't really work in Crohn's except for upadacitinib. I don't know if it's a dose thing, not sure.
So Jill, in his presentation, Badreldin actually said there was a point at which they were deciding whether to go for Uster or Vido. I mean, what would you have gone for?
I think
I'm not sure what I would have gone for, but I mean, was Uster a real option in this case, even if it was available for UC?
Yes, 100%. 100%. I must say, I wouldn't. My first thing I would have done here, I would have switched to adalimumab and given that a shot. And if adalimumab had failed, I would have probably gone to ustekinumab, a second line. Vido doesn't work as well in patients who failed anti-TNFs. It's not really great. I mean, if you can use it, of course, and there are going to be some patients that respond. And then I must say, tofacitinib, I would absolutely agree, would be the next choice.
Right. Okay. Paul, I see your hand is up.
Yes, I just wanted to ask Prof. Ali, how easy is it in Bara and Charlotte to get biologics? Just to I know you in Cape Town, you are in another country, but
not anymore. Not anymore.
How easy is it?
No, it's very difficult. I tell you, even we were allocated 6 numbers, and I tell you, even that we're fighting with, and it's crazy. Even we're using the biosimilars, and that we have problems with. But you're right, Paul. It's a disaster.
Yeah.
Sorry, a simple answer.
None, how are you guys with the allocation for biologics?
Oh, we are fortunate that we do have 10 allocations. Obviously, it's the, what do you call this, the H101 form that we have, but we've got 10 slots.
And are they
So-
all fully filled now?
For Revelex, for infliximab, right? Revelex, yes.
Are they all fully accounted for?
That one, I think Dr. Simmons will be able to give a better answer because he's the one who deals with that. But I do know that we also have a lady who's from your unit. I'm not sure if
Yeah,
you're
yeah.
aware.
I know
The lady
exactly what you're
that-
talking about. Yeah.
Yes, that she has had a infusion today. The second
Oh,
infusion.
wonderful.
Yeah, I do know. But that slot was always belonged to her before she went down to you.
Okay, we cannot divulge details, but is she doing well? She
Extremely
still-
well. She's weighing 45 kilograms, I'm told today, because I think when she
Wow.
left, it was 34 or something.
That's amazing. She's a fighter.
Yeah, she's doing extremely
Yonela,
well.
Yonela, Viji is not on. Could you perhaps tell us what your biologic availability situation is in Natal? Or anybody on the call from...
Hi, everyone. We do have, but we don't have new patients. These are the old patients, so we don't have any slots. So if the patients either die or they move abroad, we lose those slots. So they're not taking any new slots.
How
So it's
many-
all the old patients.
How many do you think you have currently, even if it's just a rough figure? I mean, what's
Probably
the burden? Yeah.
probably around 10 at most on infliximab.
Right. Yeah, I mean, it's not bad. I mean, it could be worse if you consider that before there was absolutely nothing available.
Yeah.
Yeah. No, okay, thank you. Jill, I'm trying to stretch this thing out. I've run out of
Yeah, I
questions.
know.
I don't know if you have
I
anything.
think I will just to comment to all our colleagues from South Africa. Anti-TNFs are now on the essential medicines list for fistulizing Crohn's disease. I'm hoping they will be on the essential medicines list for luminal Crohn's disease, and we've just started the process for ulcerative colitis. And this is for pediatrics as well.
Well done, Joe. Well done. After years of fighting.
We have
Years
to
and years.
hundreds of hours of putting the documentation together just to get it approved for fistulizing Crohn's disease. But typically when one chip falls, then the rest follow.
Yeah,
but
yeah. I must say they've been fantastic committee with helping take this forward.
Well, that's a big step forward because once it's on the essential drug list, then it'll
100%.
be much easier to
Yeah.
persuade your PTC committees that this is an
Absolutely.
essential therapy.
Absolutely.
I think that was the big thing that we
So
had
it
before.
is- It's officially on for fistulizing Crohn's disease as we speak, and hopefully luminal by we're hoping May, end of May, into June, somewhere around there.
Wonderful.
Well done.
Yeah. I'm just going to ask the
Thank-
fellow last round of comments or questions because I suppose we've run out of ideas. Anybody has anything else to say? Or anything, any patient experience to share? Liz, hello. How are you? Please go ahead.
Thank you. Thank
Liz,
you.
you muted.
Yeah, I just wondered, you know, in pediatrics, we have a little bit more lenience and we put people on these drugs. Then we send them to another province or up to Jill. And how do they either bump somebody else off or guaranteed of a treatment that started, they've healed? I mean, it's quite a difficult problem. Sending maybe to KwaZulu-Natal, and we've had problems that they can't get the medication there.
No, I think our drug, it would be very unethical to stop a patient who is responding to biologics. So I'm pretty sure our Drug and Therapeutics Committee would agree to continue the anti-TNF in that particular scenario.
Okay.
Mash, would you agree with that?
100%. And in fact,
Yeah,
Liz,
no,
we actually need to do more to talk about transitional care. I mean, at least between us
Yeah.
and
Yeah, yeah.
that's a gap in the service that we provide. But yeah, Julie's quite right. For us, the basic ethical principle is if a patient is on, even now with austere measures,
Yes.
will continue to get their medication.
Okay.
But
Thank
the
you.
different province, that's a different discussion, I suppose, and maybe that would be a provincial to provincial discussions into how the monies are recouped and all of that.
Yeah. Okay, thank you.
Mash, I see Catherine Edwards is on. Maybe she'd like to make a comment about the case or tofacitinib or whatever.
Hi, Catherine.
Catherine, are you
welcome.
still there?
You
Hi,
there, but
everybody. Jill, Masheke,
Hi.
see you. I'm afraid I've just been late logging in with some technical difficulties, so I didn't actually get to hear the case, and I'm very sorry about that. But it's really nice to be able to join you all today. Sorry, Jill.
Yeah.
wonderful to see you, Catherine.
Oh, lovely to see you.
Yeah. Well, you did come at the tail end, unfortunately, and today we only had one case presentation, and Joel did do an overview of tofacitinib. So yeah, we've had some very interesting discussions and all the challenges that we face in terms of our access to these agents, and obviously our inability as it stands to predict response of patients to the various medications that we have on offer.
Absolutely, but great to hear, and congratulations on getting the anti-TNF on the essential drugs. That's a major step forward, so I'm really delighted to hear.
Yeah.
It is, but unfortunately our access has completely dried up now because we've had these massive budget cuts. So, even the anti-TNF biosimilars, which are pretty well priced, are no longer an option in our setting, which is a bit of a disaster, but nothing much we can do about that.
Yeah, I guess that's going to cycle through the sort of economics of the health service in South Africa.
Absolutely. Yeah.
Rather than be driven by the science of the medicine, which is always a difficult consideration, and we're not immune to it here in the UK either.
No, for sure. I know it's around the world.
Yeah, but obviously at a different sort of capacity level. Thanks.
Yeah.
I was going to ask you about how COVID has impacted on the NHS, and we've heard that it has. So you've kind of confirmed that you also have your own kind of problems in terms of the economics of healthcare generally.
I think the big change that everyone is noticing is the workforce, and it's when I thinking back, it's 2015-16 since I was working in South Africa, but one of the things that struck me was the paucity of resource in terms of numbers. And although that was a very long way from what the UK situation was or was perceived to be at that time, certainly the workforce crisis has become such an issue here about having enough, in terms of, from our benchmark base, enough doctors to provide service. And that's actually making the long-term workforce plan, which is the NHS is producing, a really key issue, and it's driving controversy in the sense that you'll probably be aware there's ongoing industrial disputes in the NHS with medical staff. And there's also a sort of antipathy towards expanding non-medical workforce, so healthcare professional workforce, which is proving very controversial at the moment as well. So I think at the end of the day, for all the resource, it's always going to be workforce, because the actual delivery of service needs pairs of hands to actually get the work done. So we are in a difficult situation, and I do think the system here is relatively broken, and COVID produced that sort of final straw on the sort of, shall we say, the morale of the workforce. And as in South Africa, people are very tired, and people's resilience to be able to commit and extend their practice is no longer what it used to be. And it's very sad to witness. So it's a rather grim overview of where we are in the UK, but everybody's got their heads down and just keeping moving forward the best they can under difficult circumstances.
I think you've summed up quite nicely what we're experiencing. I mean, the meetings that we've been having basically since October, November, Joe, That is the general sentiment, I'm afraid. Not
Very depressing.
very
Anyway,
difficult times. But you know what? We will shoulder through. I think we just have to sort of wait it out. I mean, it can only get better. At least that's what I'm telling myself.
And I also think, you know, for our fellows listening, there is still something wonderful about the profession of medicine, regardless of the difficulties and context in which we all work. It's still a great privilege and still a great vocation. And there are very few careers that allows you such access and such abilities to make a difference, both at a system level and at a most importantly at a patient level, one-to-one. So there's light. It's just occasionally it feels as if there's a bit of load shedding with the light.
I could not have said it better, and I think that is a fantastic note on which to end this meeting. Jill, do you agree?
I agree, 100%.
All right, so I want to start by thanking Dr. Badreldin and Professor Komu for actually coming to the party and doing the case presentation on this occasion. We really, really appreciate it. We have reached out to the other training centers. Please, guys, this is the platform where we really want you to present your, your cases, your challenges. And like today, we've had a discussion basically about what's happening nationally in terms of access and so forth. And I think these conversations are important. So thank you. And Jill, thank you so much for your presentation, basically coming to the rescue to help us. And then I just want to thank iEcho, the iEcho team here, locally Cheryl and Karen, and the India team who actually have been fantastic. All the recordings, as you're aware, are available on the Gastro Foundation website, going back since we started these virtual meetings. And I want to thank Chris and his contribution to our work. And then thank all the sponsors, without whom, of course, we cannot host any of these meetings. So just to remind you that next week is patient blood management. And then I just want to remind everybody, I hope that by now you have registered for SAGES. And we hope to see you there. Wednesday is pre-Congress, as well as the abstract presentations, and then the actual meeting starts on Thursday. There's a plenary with all of the societies, and we really hope to see all of you there. I don't have anything else.
No meeting next week. Is that right, Mashiko? There's no gecko next week.
There's no meeting next week.
Oh, okay. Apologies. There's no meeting next week.
Because of our combined meeting. So we'll pick up with, I think, pathology the week after, but we'll advertise it, yeah.
All right. Thanks, Chris, for that.
Thank you.
So thank you to everyone on the platform, and yeah, looking forward to seeing you next week. And Catherine, stay well, and I'm sure we'll see you back in South Africa soon.
Cheers.
Cheers. Bye.
Thank you. Cheers.
Bye.